given by Dr. Uma Pisharody, who is a pediatric gastroenterologist at Swedish Medical Center in Seattle and Issaquah. She is passionate about helping children and families understand the connection between diet, nutrition, digestive health, and well-being. She did her residency at Jersey Shore University Medical Center and a fellowship at Louisiana State University Health and Sciences Center. She is a member of the Crohn's and Colitis Foundation Medical Advisory Committee and is co-medical director for the foundation's Camp Oasis, which is an amazing program. Her presentation today is entitled "The Top 5 Things to Know About Your Child's IBD." Thank you so much. Oh, we can't hear you yet.
It looks like you're on mute.
Am I good now?
Yes.
Okay, and you can see the slides?
Yes.
Okay, let me get started here. I'm gonna try to spend the next 30 minutes or so going on a very pediatric focused talk. And before I get started, I just wanted to thank the CCF, the organizers, Dr. Bode and Dr. Chiori, and of course, Jody, for putting this together, and all of you out there listening. Thank you for taking the time, especially on a Sunday morning. So as was mentioned in the introduction, I'm a pediatric gastroenterologist. And after having done this for 10 or 15 years, diagnosing and treating children with this disease, when I got asked to speak on this topic, I really pulled this out of the top of my head thinking after 10 or 15 years, what are the top 5 things I get asked over and over, the top 5 things I would love for my families and patients to know in their hearts about this disease. And that's how I pulled the slides together. None of this is really out of a journal article or any science based. It's really sort of evidence and based on just years of experience. So I have started this because I think, especially for anyone who is just newly diagnosed, sometimes we lose sight of the forest for the trees, or we get lost in the weeds, and we're so focused on, my child and their diagnosis and what medication and what side effects and when is the next infusion and all of this. And this is sort of a step back. This is a bird's eye view of the disease in general. How do I, as a pediatrician, treat a child with this disease? What is the long-term goals? What is the scope that this disease is going to have on the child? And so that's where this talk is going to head as we go through each of the 5 top topics. And I think it's overwhelming when we're diagnosed, especially when it's our child that's diagnosed. And if we turn to Google or certain sources, sometimes there's too much information. There's so many sources that we can get overwhelmed. And so this is sort of a talk to hone it all down. I've divided up my talk into sort of 5 big categories, and the majority of the time will actually be spent on category number 1, and I've sort of color-coded my slides so it's easy to remember which part of the talk we're in. I'm going to talk about the why, because even though it's maybe not mentioned, I think parents often wonder, why my child? Why did this happen to me? Could I have done something different? It is something about what I fed my child. Is it something that I could have done in my pregnancy differently? And I don't want anyone to ever leave an appointment thinking that. There's no one to be blamed for this. And so I do focus a lot of my talk on that first section, the why, what caused this disease. And also I get asked many times about what can I do to prevent this in another family member, especially in a sibling of the child that's now been diagnosed. Briefly, I'll touch upon the importance of education, and this will go to Dr. Lord's topic of advocacy. How can we self-advocate? How can we teach ourselves to be better patients with this disease? And then in the same vein, what can we avoid? So there are certain, few things that I hope all families know. There are certain medications to avoid if we can, certain things we can do to advocate for ourselves when we're traveling or when we have to go to the emergency room. I will briefly touch upon the role of diet, because even though there was an entire wonderful talk dedicated to this by Dr. Suskind, it's probably the top question I get asked as a pediatrician. What can my child eat? What can they not eat? What diet may prevent a flare? And so I will just sort of spend a few minutes on that, and we'll close with sort of how I treat this disease as a pediatrician. What is my goal when I diagnose and treat a child especially? And I put this talk together because I think it's important, because even though some of these things may come up and be spoken about by the doctor who's treating your child in that first visit. I think the first couple of visits when you might get the most education are the most overwhelming visits. And so a lot of this may go in and come out the other ear, and we may not have time to remember all of this. So even if this is not a new diagnosis in your family and you've been dealing with a child with this disease for several years, I think some of this could be a good refresher. So topic number one, why? So why my child? And like I mentioned before, I don't want anyone to ever think that they could have really done anything to prevent this disease. After nearly 100 years of having Crohn's and colitis being discovered, we still don't even know what really causes it. So of course, we don't know how to prevent it. And even treatments are, still ongoing in terms of research, and what type of treatment works for everybody is still a question to be solved. But there really are two big sort of risk factors for why anyone develops inflammatory bowel disease. And that's a combination between something with our genetic predisposition and the environment and the environmental triggers. And the way I think about it is that genetics affects how our immune system works, and the environment affects how our microbiome is formed. And it's this interplay between these two factors that ultimately may or may not result in this condition that we call inflammatory bowel disease. It's the end result of multiple pathways. There's different types of inflammatory bowel disease. It's not even just Crohn's disease and ulcerative colitis. There's so many, subclassifications, but the ultimate end result is because of these two broad categories, something with the genes playing with something with the environment. And I will just talk about the genetic risk first, because this has much more of a role to play when it comes to pediatric patients. It's said that 1 in 3 children with inflammatory bowel disease probably has a family history of that disease. This is much different from when we're talking about adults with this disease. In fact, it's probably 80 to 90% of adults may not have a family history. And it's almost virtually the opposite when it comes to a kid. 1 in 3 probably has a family history. And not only a family history of IBD, but probably the same type of IBD. So it's more common that if you have a parent with Crohn's disease, a child will develop Crohn's disease. It's not likely that they're going to develop ulcerative colitis if the first degree family member has Crohn's disease. Genetics plays much more of a role in Crohn's disease as opposed to ulcerative colitis. It's almost double. Somewhere in the realm of 10 to 20 times increased risk for a child to have this disease if a first degree family member has inflammatory bowel disease. And that's about double for Crohn's compared to ulcerative colitis. And then if a child is in the sad state where both their parents unfortunately have inflammatory bowel disease, that child unfortunately will have a 1 in 3 chance of developing the disease relatively young, before their age of 30. But genes only part of the equation here. As I mentioned before, the way I like to say it is the genes sort of load the gun, but it's environment that pulls the trigger. And what in our environment is pulling the trigger for the children that we're diagnosing, we're not exactly sure, but these are some of the theories floating around. And it's probably not just one of these. It's probably a multiple hits at the same time. So is it something to do with our diet? Could it be refined sugars, the ultra processed foods, the so-called Western diet, where a lot of the foods come out of packages or cans, and there's a lot of industrial processing going on? Is it a diet that's higher in animal protein? Studies have been done to look at this. Is more inflammatory types of fats like the omega-6s versus the omega-3s? We do know that there's a role of nicotine. Even secondhand smoke exposure can increase the risk of certain types of IBD, Crohn's disease especially. Of course, the bacteria, and this is what Dr. Susskind was talking about, the bacteria, our gut microbiome, is probably the biggest environmental factor that can pull the trigger of the gun, which is loaded by the genes. And this goes to the hygiene hypothesis. Many of you must know what the hygiene hypothesis is, but in a nutshell, basically it says that if we're exposed to small infections at the right times in our development, our immune system may be able to tolerate further infections or inflammatory triggers later on in life. But for some reason, if we're brought up in a much more sterile environment and there's a lot more hygiene, because our guts and our immune systems aren't being exposed to the right triggers at the right times, then when we do get a small infection or a relatively benign infection, our immune systems may be triggered to go into overdrive and go the other extreme into autoimmunity. There's been studies to show that a child who's had their appendix removed, so they've had the appendectomy surgery, they are more likely to get Crohn's disease, but there's also been studies to show that they may be less likely to get ulcerative colitis. There's been risks shown with repeated exposure to environmental antibiotics or environments that are more hygienic, that we are more likely to have a disrupted gut microbiome and develop these autoimmune diseases. And it's not just for Crohn's and colitis, but it's for most autoimmune diseases, which I will show in a slide coming up here. I think this is a very telling slide that shows where the prevalence and incidence of inflammatory bowel diseases. We all know that it's much more common to find these diseases in the northern latitudes and the most developed nations, the United States and the UK being the top 1 and 2 nations in the world with these diseases. That being said, we are seeing an increasing rise and prevalence of this disease in people of ancestry of developing nations, for instance, the Indian population. And I, coming from India, was very interested in this. So I did my medical schooling in India. And I remember in the 1990s learning about Crohn's disease in my medical textbook. And it was basically half of a page and basically telling me that this is a disease of the Western world. You're probably never going to see it in your career here in India. And then when we moved to America, we're starting to see so much more of this, even in the children of that native Indian ancestry. There's a study actually showing this, that there's a high prevalence of inflammatory bowel disease in the United States, and that's in people of Indian ancestry. And not only do they develop this disease much more commonly than they might have originally in the original country that they're from, but it's a much more aggressive form of this disease. So it's definitely not just the genetics, because nothing changed in the genetics of this population, but it's the environment to which they were exposed that seems to increase their risk of the disease. So that's what we've seen. We've seen over the last 20 years that there's nearly a doubling of the incidence and prevalence of Crohn's disease and colitis. I remember as a fellow learning that there's about 1 to 2 million people with Crohn's and colitis in the United States, and now the numbers are 3 million, so doubling just in my career span. We know that about 5% of people diagnosed with this, whether it's the United States or the world, are children. And that not only is the prevalence at about 5%, but the incidence. So when you take the new cases diagnosed per year, about 5% of those are for kids. And as I mentioned before, it's not just for Crohn's and colitis, but we've seen a increasing incidence of all autoimmune diseases. If you take multiple sclerosis, asthma, type 1 diabetes, all of these diseases over the last 20 to 50 years have been increasing in incidence and prevalence. And this is probably because of something in our environment. It's certainly not our genetics that have changed in the last 50 years. This has got to be something triggered in our environment. I've got 3 slides here that I think are very telling about the importance of environment and the interplay with environment and genes. So these are actually studies done in a lab with mice, or rats, I should say. And this is a rat that's been injected with an HLA-B27 gene. So HLA-B27 is a protein that makes us more likely to develop autoimmune diseases, especially ankylosing spondylitis, ulcerative colitis. Certain types of autoimmune diseases are more likely if you carry this gene. So they took an HLA-B27 gene and injected in a rat. And if they grow this rat in a germ-free environment, the rat does just fine. As far as their colon is concerned, no colitis. As soon as they expose this rat to normal bacteria that would otherwise live in a rat's cecum, or the right side of the colon, this rat will develop an aggressive form of colitis. And then if you expose this same rat to only Bacteroides vulgaris, which is a specific species of bacteria, the colon gets inflamed, but only mildly. And then if you expose this same rat to just E. coli, which is another type of bacteria, there's no colitis. And then interestingly enough, if you take that rat and expose it to those cecal bacteria that would have otherwise formed an aggressive type of colitis, but put in there a probiotic bacteria, namely Lactobacillus GG, that same rat with the same genetics, with those same bad bacteria sort of inserted, is now protected and develops protection from any sort of colitis. Here's another example. IL-10 is a gene that actually protects us against inflammation. So it's almost the opposite of HLA-B27. Having IL-10 helps us prevent the development of any autoimmune diseases. So if we take IL-10 out of these mice or these rats and grow them in the lab, we can see what happens to them when they're exposed to different bacteria. So an IL-10 deficient mouse, if grown in a germ-free sterile environment, is protected from any colitis. That same mouse, if presented with a normal amount of commensal bacteria that should live in the gut microbiome of any mice, develops colitis. That same mouse, if presented with E. faecalis, a specific species of bacteria, develops colitis, especially on the left side. And then that same mouse, if exposed to E. coli, specific species of bacteria, will develop colitis, but mostly on the right side. And then this is the last slide, which I think really brings home the point that it's not just the genetics, nor is it just the microbiome, but it's so specific and nuanced to this, the person themselves, which is where if you take the IL-10 deficient mouse or the HLA-B27 mouse, and these are both now mice that have a predisposition genetically to develop an autoimmune disease or colitis, but you grow these mice in a culture of specific bacteria, one gets minimal inflammation, one gets horrendous inflammation. So it is really an interplay between the gut microbiome, the environment that helps that microbiome thrive or not thrive, and our genetics that causes these differences in how we develop or don't develop inflammatory bowel disease. So I think the take-home point is really that we still don't exactly understand what causes inflammatory bowel disease. So there's no blame game here. There's nothing really we could have done. We all know of parents who have two children, one develops the disease or doesn't. There's studies in identical twins where one gets the disease and one doesn't. So it's really beyond our control right now. There's nothing we really can do to prevent the disease specifically. We don't know if this is a normal response to an abnormal stimulus versus an abnormal response to a normal stimulus. We don't even know which is the chicken or the egg yet. So I really wanted to hit home on the point that, you know, once the disease happens, I don't think it's worth thinking back or trying to second guess ourselves, that we just move forward as a team and we get your child feeling as good as they can. And this is how I'm going to close that first topic of the 5 that we're going to go through, which is that this is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. I'm going to move on to the second topic, which is the advocacy dichotomy, because I think a lot of families, when they find out that their child has Crohn's or colitis, there's this dichotomy between advocating for you, specifically your child, and then looking into the big picture about the disease in general. And for a lot of us, we turn to the internet for this. And I think on the internet, things can look a lot scarier than they need to be. And so we need to be very specific on what we're looking for. And that's what the next few slides are going to go through. So a good example of this is, you know, you will see that on the Crohn's and Colitis Foundation's website, it says the risk of getting inflammatory bowel disease in general in the United States is about 1 in 200. But the moment your child gets it, all those statistics go out the window, and now it's 110% my child has it. No more 1 in 200 for you. So a lot of the things you're going to look on the web have to be taken with a grain of salt. Once your child has it, everything's skewed. So we really need to be careful where we're going for our information. And I think after years of doing this, these are probably my favorite websites. And so I've listed them here for you. Of course, the Crohn's and Colitis Foundation, that does nothing else but advocate for you and your children. GI Kids, which is the North American Society for Pediatric Gastroenterology's website, and it has disease-specific information about Crohn's and colitis, really pediatric focused here. UNIBD is a nice website. It's supported by the American Gastroenterological Association, and it has nice animated videos if you're trying to learn more about the disease. It has some quizzes you can take to try to learn more about the disease. On YouTube, I love the University of Michigan's IBD site. They have little snippets and videos and educational talks that we can go to when we have questions about different topics. And there's hundreds of videos there that I find are very valuable. And then the last one, this is just like me, IBD.org, which is through the Crohn's and Colitis Foundation, but this is a site specific for tweens and teenagers. So that pre-adolescent age group will find this section of the Crohn's and Colitis Foundation website much more applicable to them. Of course, every patient that I have, I highly recommend joining the Crohn's and Colitis Foundation because the information they provide is like none other. I do want to make sure that you're all aware that if your child goes to a publicly funded school, they are eligible for an individualized education plan, the so-called 504 plan, which is a federally mandated law. And this gives them the right to a specialized education plan that can make up for any medical excuses when they need procedures, when they have to see the doctor. They should be able to have protection for that. And I definitely want to make sure all parents of children with this disease know that they're eligible for that. And whatever you do look up online, I want to make sure that you're involving your child's doctor and nurse. It may not be something you want to bring up during the visit, but at least you could call and speak to the nurse and run through things with them. And more than anything, the take-home point from this part of the talk is just like your child, his or her IBD diagnosis is very unique. It's very hard to extrapolate data written by a dietitian on general diet for Crohn's and colitis out there when it's your child and their type of disease may be so unlike any other child's disease. And you can't extrapolate data from the adult studies on nutrition to a child's experience on nutrition. So we really have to take a lot of the information we get when we do generic Google searches or internet searches with a grain of salt. And in looking up this information, I just came across this and I thought it was funny. I mean, if you look up Crohn's and colitis and you're just sort of looking for why it happens, these are the things that are out there. Crohn's disease, what doctors won't tell you, as if there's some sort of conspiracy theory out there. And they're basically, they tell you a few half-truths, such as that Crohn's and colitis is more seen in the Western world, which it certainly is. But then they sort of take a skewed look at that and they say that it's because of the Western toilet. And that if we all went back to squatting toilets, we wouldn't develop this disease. So it's that, weird combination of a little bit of fact with a lot of untruths. And this is the kind of stuff out there that's being sold to you. So you really need to have, a judgmental approach when you go to the web, and you need to use reputable websites, of course. And then a lot of the information online is, I think, geared towards adults with this disease. And there's a big difference between pediatric or early onset IBD and adult or late onset IBD. That's what this slide is meant to show. So in pediatric onset IBD, the colon is most often involved, and it's often pancolitis, diffuse involvement of the entire colon right from the get-go. We see much more rapid disease progression. And in ulcerative colitis, again, pancolonic disease often at onset, more likely to extend within the first decade. And in both of these diseases, probably a shorter time from diagnosis to colectomy. Sorry, that's specific for UC, but for both of these, probably a shorter time of illness before you find out that you have a severe disease. Whereas with adult patients, they probably have a milder degree of disease initially. They're more likely to have just involvement of the ileum. It's less extensive. Disease extension is less common. It's often localized or left-sided, and they can often go years, if not decades, before they need a colectomy or even their first surgery. So that is why in pediatrics, we often treat more aggressively. So many patients may come to me and say, well, I have an uncle or a great uncle who had Crohn's disease and was just on, a 5-ASA or a mesalamine. How come my child is being put on a biologic right within 2 weeks of the diagnosis? And so these are sort of some of the things that we pediatricians know, that children fare worse. Children get a more progressive, aggressive form of this disease. So we need to fight back just as aggressively at the disease onset. And this is what this slide is meant to show. This is from last year at the Crohn's and Colitis Congress in Europe, where they show when we make a diagnosis, if you can see my pointer here, when we make a diagnosis, it's really some time even after the disease onset. And we really have this small sort of window of opportunity where we can intervene appropriately, and sometimes it needs to be aggressively, before we are getting into these areas where you have a lot more disability, the disability being the red line, and you're having outcomes that require more likelihood of surgery. So we want to be aggressive and appropriate and treat early. And if you're interested in knowing more about that approach, this is the website. This was the 2018 Congress of the European Crohn's and Colitis organization. And I loved how the first speaker sort of boiled it down. He said, you know, it's the right concept, the right time, the right drug, the right target, the right team, the right monitoring. So that's how we think of it as pediatricians. We're treating, we're not giving aggressive therapy, we're giving appropriate therapy, appropriately aggressive at the right time, because we know we have this small window. And this is coming to a close on the second of the 5 big topics I wanted to cover this morning. And that's for us as to be good advocates for ourselves and for our children with this disease. We need to know the basics of their disease. Time and time again, we hear about patients who ended up in an emergency room, or I'm called to take care of in my emergency room. And while the parent or the child may know that the child has inflammatory bowel disease, it's unclear to them whether it's Crohn's or colitis, which parts of their bowel are involved. They can't remember their medications. They can't remember their dosing. And I know this is all overwhelming. And especially when your child isn't feeling good and you show up in an emergency room, some of these things may just escape your mind. So it is a good idea to have some of this stuff written down. We now have apps available to us. These are 3 apps that I think are probably the best. This is the IBD manager from the American Gastroenterological Association. This is just the regular health app from Apple, if you have an Apple phone. And then MyChart is the chart access application that some of us have through our doctor. Whatever app you use, or if you're just writing these things down in a notepad, we should know the few basics, which is, what type of disease does your child have? Maybe even when was it diagnosed? Your doctor's name, a nurse's name, a telephone number. What sites would be awesome if you could tell a doctor that the disease is in the small bowel or the large bowel, or even more specific to that, is it in the ileum or is it in the right colon? What are the symptoms of a flare? What were the symptoms when this child was originally diagnosed? Would be very important information for me to know, because we know that IBD, what we say is flares true. So if you usually have left-sided lower abdominal pain when you're having a flare of your disease, where if you come to me and said, all of a sudden I write lower-sided pain, I'm more likely to send you maybe for an appendix ultrasound, thinking that you could have appendicitis, and not just jump to the conclusion that your pain right now is from a Crohn's or colitis flare. So we often go back to those original symptoms that your child may have had when they were first diagnosed. So to remember those, to have them written down, is very helpful. If they usually have fevers during a flare, then that's one thing. But if they've never had a fever with a flare before, and today they have abdominal pain with fever, that is something new that we need to know about and can change our medical decision making process in the office. And then lastly, of course, know your child's medications, at least the names. It would be also very helpful if you could know the doses. So we're going to move into the third section, which is some of the things I want patients and families of patients that I take care of to know to avoid. And this, basically is broken down into the dangers of CAT scans, steroids, emergency room visits, live vaccines. I wanted to briefly talk about some dietary things like grapefruit and vitamin D, and then NSAIDs, which are non-steroidal anti-inflammatory drugs. So starting with CAT scans. CAT scans involve a lot of radiation. It's said that one CAT scan is the equivalent radiation of 400 chest x-rays. And so if you're in the emergency room, or if you're seeing a care provider that wants to run a CAT scan or order a CAT scan on your child, at least ask if there's a better option available, such as an MRI or an ultrasound. Neither of those studies involves any radiation to the child's body, and we're especially vigilant about radiation in a child. And because they have a disease where imaging may be necessary throughout their life, we want to reserve a CAT scan for those really important times where no other alternative is possible. All too many times I see children who've been in the emergency room and a CAT scan is done just because it's the easiest test to get most of the answers done in that moment. And I wish that parents know about the risk of CAT scans and can have that discussion with the provider just to make sure there's no other option available. Steroids. So I think adult gastroenterologists may be more apt to prescribe steroids than we are as pediatricians. My sort of go-to game plan is to avoid steroids if and whenever possible, and that's really because of the growth suppressing effect it has on children. And this isn't something that we need to worry about when a child is grown up. So in treating adults, we can probably advise even a short or long-term course of steroids more readily than if we're treating a child, where we want to avoid steroids as much as possible. So if your child has been on repeated courses of steroids, that's a discussion you need to have with your care provider about why is this? Was there any other option? Should I be advancing therapy to something else so that I don't have to rely on steroids as often? Emergency room visits. So these are necessary when they're necessary, but sometimes they can be avoided by just picking up the phone or chatting with your doctor's nurse, and trying to maybe be seen in the office first, or maybe the doctor can talk to the emergency room doctor before you get there, so that the emergency room doctor won't rely on a CAT scan or sort of not know what to do with the child once they present. Because if we can have that discussion in advance, or we can see you in the office first, we can avoid not only costly visits, which the emergency room often is, but a lot of time wasted, because between getting to the ER and waiting there and being seen by a provider that doesn't really know your child or what they've been through, emergency room visits, if at all possible, should be avoided. Live vaccines for anyone who's on an immunosuppressant or a drug that lowers our immune system's readiness to fight another infection. We don't want to give children a live vaccine. So whenever possible, we want to give them the killed form of that vaccine. The most common live vaccines that are available today are the flu mist and the MMR vaccine. So these are both contraindicated in children on immunosuppressants. Less commonly needed, but also things to think about are the yellow fever vaccine, which is live, BCG, not really given nowadays. Oral polio vaccine is also a live vaccine. This is not used in the United States. And the rotavirus vaccine, which is given primarily to infants, is also a live virus vaccine. But the ones really for most kids that we need to think about are the flu mist and the MMR. Grapefruit, I'll touch upon briefly, which is that it can interfere in the absorption of certain drugs. This isn't common with most of the drugs that we prescribe for IBD, but it is something to think about. And while grapefruit is a great food with a lot of fiber and a lot of micronutrients, great for vitamin C, it shouldn't be taken at, within a certain time of taking certain medications. And so this is something to discuss with the pharmacist, whether grapefruit will interfere with the absorption of any of the medications that your child is taking. Vitamin D deficiency to be avoided at all costs, especially if your child has Crohn's or colitis. And I have 3 slides coming up that explain specifically the importance of vitamin D. And lastly, non-steroidal anti-inflammatory drugs. These are the drugs we commonly refer to as ibuprofen or Motrin or Advil. These medications may interfere with the healing of the bowel when you have inflammatory bowel disease. This is somewhat controversial. While we have mechanistic data to show how anti-inflammatory drugs like NSAIDs could potentially cause harm in the gut, when you look at big clinical studies and look at what's really doing in the general population, not a lot of harm has been found. So if you need to take one, it is okay, but I think it's important to know why you're taking it. If anything, be upfront with your doctor and explain to them that you're taking this much ibuprofen per day, because maybe there's something I need to be doing on my end to avoid you needing that kind of medication. Am I not treating your inflammation? Am I not treating your pain? Because if you're needing NSAIDs at this much, it's something that I need to be aware of so we can get you on a better form of therapy. And then lastly, with steroids and NSAIDs, both of these medications do need to be taken with food, and they can both run the risk of getting gastritis. So a lot of time when you're on steroids or you're taking NSAIDs, we may also tell you to take a short course of an acid blocker. These are 3 slides just to show you about the importance of vitamin D. So this was a study a few years ago that actually showed that there was a higher vitamin D status was associated with reduced risk of Crohn's disease. So these researchers for almost a quarter of a century, over 22 years, followed over 73,000 women. And twice a year, they would send them a questionnaire asking them several health questions. And they basically, at the end of 22 years, showed that there seems to be a relationship with those people who were taking vitamin D, who had higher vitamin D status. They had a lower risk of ultimately developing several autoimmune diseases, including inflammatory bowel disease, including Crohn's disease. So they concluded that a higher vitamin D level significantly reduced the risk of developing Crohn's disease. So that's something to think about, what vitamin D can do before the onset of the disease. This study is actually showing that vitamin D levels may even predict or definitely respond to treatment of a flare. So they showed that if you had a lower vitamin D level, this was associated with disease activity. And then once you treated that flare, once you actively were able to manage the flare and put that person into remission, then their vitamin D levels went right back up. So that is also important to know, that vitamin D can be affected by how well your Crohn's or colitis is being managed. And then lastly, this is a really important study that what they did was they were able to show that the higher your vitamin D level was pre-treatment with infliximab or Remicade, the more likely you were to respond to that Remicade dose. So there was a more durable effect to the Remicade if you had a pre-treatment vitamin D level that was higher. So we don't want to be vitamin D deficient, is the take home. Pre-diagnosis, during the diagnosis, with the treatment, vitamin D is a really essential micronutrient that we need to be paying attention to, especially with children. I'm coming to a close here. I've got just the last two topics. As I mentioned before, I don't think a visit ever closes with one of my patients without me being asked about diet and nutrition, or myself bringing it up, because I do think it is so important. I know that Dr. Susskind spent, close to an hour speaking on this, but I do want to just sort of give you my nutshell spiel on this. And I think that just like we talked about with advocacy and Googling Crohn's disease, there's no one diet that fits all. It depends on the age of your child, it depends on the disease type, it depends on where their disease is, the location, the phenotype, whether they have a stricture, whether they have an abscess, whether this is small intestinal disease. But some broad take-home points with diet and nutrition is that we could all do with a little extra vitamin D. So eating foods that are high in vitamin D, taking a vitamin D supplement is specifically one thing we could all probably do with our diet and nutrition. I mentioned the grapefruit example about grapefruit, even though it's a great food, it needs to be taken with caution with certain oral supplements, and that's just a timing phenomenon. And then probably the two diets that have been specifically studied in terms of pediatrics are the SCD, the specific carbohydrate diet, and the exclusive enteral nutrition diet. And these have been really shown in the right population to work very effectively. EEN works really great in kids, can spare them the effect of steroids, but it's the long-term goals with these diets that we're not so sure of right now. It's hard to maintain some of these diets, but they're very good diets. And I think the take-home point from any diet that you want to do is that we should basically eat real food. As I mentioned before, those people that you take from India where they may not be getting Crohn's and colitis, and you put them in a Western culture, we don't know what it is, whether it's the Western diet or if it's the microbiome change or the hygiene hypothesis, but certainly there is a change from probably eating less processed foods to more processed foods. And so whatever you can do to focus on eating the food that Mother Nature wanted us to focus on. So less processed, less chemically refined, less refined sugars, and we can do whatever we can to focus on eating real food will probably be the best nutrition and diet take-home point from this talk. This is an interesting slide, which I thought was almost funny when I first saw it, but what it does is compares the different diets, and each of these diets has been researched and studied and published and purported to be effective for Crohn's and colitis and various autoimmune diseases. And I think it's wonderful how they show that literally some of the foods that are mandatory, which is that dark teal color, literally mandatory in some of these diets, is absolutely not allowed or prohibited, which is the brown, in certain other diets. So how can it be that a diet that's shown to be anti-inflammatory, that incorporates one food group, is absolutely contraindicated in another diet, which shows also benefit in the same disease, which just shows that these diseases are nuanced, the diets are nuanced, and no one size fits all. And then lastly, I think the other most common question that I get asked is sort of, what's the therapy and when are we going to get off of it? Because I think when we're in the moment of being diagnosed, we think, okay, so my child's going to be on Remicade. This is going to be for 2 months or 2 years, and then we're going to stop this therapy. So I always sort of want to explain as a pediatrician how I approach treating this disease. And that's really in terms of life stages. I want to get your child a normal quality of life. And so what a normal quality of life for one child is may differ from another child. If I try to focus on diet from the get-go in a child who hasn't been feeling well for 6 months, it may be pushing the limits for that one child to also focus on what he eats at this moment. So I may gradually introduce dietary changes for this child, but there may be another child who's more motivated than I am about changing their diet, and diet may enter their therapy regimen earlier on. So I think it really is nuanced. We try to focus on the age of the child, their interests, what are they willing to take on at this moment. Sometimes we may choose IV medications because that's easier for the child to do than a subcutaneous injection at home. We really are trying to get this child through certain life stages. So I think about a child who may be 8 or 10 when they're diagnosed, and I think I've got to get this kid through elementary school, middle school, high school, at least into college, and then maybe we can talk about coming off of medications or changing up therapy, because it's my goal as a pediatrician, and your goal obviously as the parents, to get this child through their childhood and on to being a healthy adult. So I think we think of it a little bit differently as pediatricians when we're treating this disease, because we're also thinking about the life goals and the quality of life in terms of what a child can handle at this point, because every age is different. This is my last slide. And I just wanted to close by saying that you guys are my heroes. You parents out there dealing with this disease, you're really tough. You know, IBD is a tough disease, but certainly one thing I've learned through having the honor and privilege to know a lot of you is that you guys are some of the toughest people I know, and you teach me how to be a better person every day. So I hope some of these slides were useful to you. I'm happy to take any questions at this time.
Hi, thank you so much. What a wonderful and comprehensive talk. I do not yet have any questions from the audience, so if there is someone who has any pressing questions here, please bring them in quickly, and if not, we will move on, but that was an amazing talk. Thank you so much. Okay. I don't see any questions coming in. If people have questions, please send them in and I will send them